Hello friends, Indian Chess Society, in association with its educational partner, Glenmark, has finished 15 Respinars, which involved nearly 100 pulmonologists all across India, from all the regions, and also had very interesting topics for the discussion. And it goes a long way to say that nearly 50,000 people logged in to watch this Respinars. It has become popular in our respiratory community. We are moving ahead, and in the month of May, we are going to bring you a hot mix and controversies in various respiratory topics in coming days. Keep watching them, and also remember, we have started along with API EPICS webinar, which is not only for the respiratory physicians but also from the physicians, and it is in association with API. Keep watching that, which is twice a month, and of course Respinar, which you have patronized so well in the last 3 months that we have reached almost each and every corner of India with the topics so interesting, intriguing, with moderators doing excellent job and bringing out the best from our panelists as well as experts who are the top-notch pulmonologists in India. Keep watching and keep enjoying and keep sending your feedback to us. And I'm Dr. Deepak Talwar, signing off as well as requesting you to continue watching these Respinars. Still coming here. Okay. Shall we start? Give me the countdown. Good evening, everyone. As promised, Indian Chess Society, in association with its knowledge partner Glenmark, brings you the first in India and first perhaps the GINA 23, which is going to be discussed today. And we all know that this is the hottest topic. So the hot mix, I can't think of anything better. And if you look at the galaxy of stars which are sitting here today to discuss this, I think it will be one of the most interesting Respinars which we had in the recent times. Today's Respinar is going to be moderated by none other than the person who's considered as one of the senior most teacher, mentor for all of us, and that is Dr. S.K. Katiyar. He is formerly the professor and head Department of Tuberculosis and Respiratory Diseases and a superintendent-in-chief at LRR and Associated Hospitals, GSVM Medical College at Kanpur. And I hand over to Dr. Katiyar to take us through the proceedings today.
Thank you, Dr. Talwar, and good evening to all of you. And can I share the screen, please? Yeah. So, friends, as already said, hot mix in asthma, GINA 2023. And look at the galaxy of speakers that we have. We are very honored to have very senior people with us this evening. Professor S.K. Jindal, who happens to be the teacher of teachers, who has been heading the Department of Pulmonary Medicine at Postgraduate Institute at Chandigarh, and now is the medical director at Jindal Clinic at Chandigarh. Dr. Randeep Guleria, who was heading the Department of Pulmonary Medicine, Critical Care and Sleep Medicine at All India Institute of Medical Sciences. And he was such a figure during the COVID time, a guiding figure, because the nation was looking at him, and the whole crusade of COVID-19 was guided by him. Then we have Dr. Raveen Sarnaik, who is consultant at Leela More Chest Hospital, Chest Clinic and Critical Care Unit at Nagpur, and he is the incoming president of the Indian Chest Society. So we are lucky to have him also with us. And of course, Dr. Vijay Kumar, pulmonologist at Hyderabad at Chest Center, and he happens to be the organizing chairman of the NAPCON 2023 being held at Hyderabad. I am sure it's going to be a great show, And it's so nice to have him with us. And of course, Dr. Deepak Talwar, who has been the driving force behind this whole webinar, which is being held at a very short notice, because it's only yesterday that we were observing the World Asthma Day. And the GINA report was released only yesterday, and we could get hold of it and are discussing it. So we none of us could really get enough time to go through it deeply, and we'll try to do our best to find out things which are new in it. Now, the World Asthma Day this year's theme is Asthma Care for All, and the Global Initiative for Asthma, that is GINA. A word about it. It was established by WHO and the US National Heart, Lung and Blood Institute, NHLBI, in 1993 to improve asthma awareness, prevention, and management worldwide. But since 2014, GINA is independent now, funded only by the sales and licensing its reports and figures. It started in 1993, and this is 2023, and they're celebrating their 30th year in 2023. Little more details about GINA. Many countries have their own asthma guidelines, and many of these are based on GINA. However, most national guidelines, unfortunately, are updated only infrequently. So they may not be truly reflecting the current best evidence. So once the guideline is made, it is not updated for quite long periods of time. So what the guidelines tell you often is not the up to date things. It takes several years for updating these guidelines. In contrast, the GINA strategy is updated every year based on a twice yearly cumulative review of new evidences. Hence, even when national or local asthma guidelines are available, the GINA report may provide a useful resource for clinicians, both primary care and specialists, to be aware of the most recent evidence and to understand how it can be integrated into holistic asthma care. Asthma, as you all know, is a disease which is very commonly seen and is responsible for a lot of morbidity and mortality. There are about 300 million people worldwide who are suffering from it, and about 45 to 70% of them have a mild disease. Inhaled corticosteroids, as we all know, have been the mainstay in the management of asthma as a regular preventive therapy, and beta-2 agonists typically taken as required to relieve bronchospasm. Poor adherence has been a problem, always a problem, it's common, and it increases the risk of exacerbations, morbidity, and mortality, often because of over-reliance of patients on beta-2 agonists, thinking them to be the main therapy, as these provide a quick relief. So the patients think that this is the main therapy, keep on taking it, and they do not bother about the preventive, the controller part of it. And that's why often the morbidity and mortality is very high because of the over-reliance on beta-2 agonists. There has been a change in strategy. GINA no longer recommends treatment with SABA alone without ICS in adults, adolescents, and children above 5 years because of the risk of severe exacerbation requiring emergency department visits or hospitalizations and asthma-related deaths. These risks are markedly reduced by ICS-containing therapy, fixed-dose combination inhalers containing both a steroid and a fast-acting beta-2 agonist, what is called as FABA, in the same device. It simplifies the therapy because you have got the same inhaler is used for the maintenance, and the same inhaler is used for a quick relief as well. So that makes the things very easy for the patients, and simplified treatment so that there are no confusions. ICS inhaled corticosteroids along with formoterol meets these requirements and can be used for both maintenance therapy as well as on as needed basis treatment during emergencies. So yesterday, this document was released by GINA, the updated 2023 report, and what is new in these GINA report 2000? Sorry for this mistake. 2023. We'll discuss about the new things which have come up in this report, and then our experts are there to give their comments and suggestions and what they think about these changes. So this is what is the old 2022 report, wherein if you look at here, the reliever in the treatment was, it was a two-track treatment, track 1 and track 2. In track 1, the reliever used was as needed low dose inhaled corticosteroids with formoterol, whereas in track 2, the reliever was as needed short acting beta agonist only. So short SABA and ICS with a FABA or LABA. Now, the change that has occurred in this 2023, they have added the track 1 remains the same. Reliever is as needed low dose ICS formoterol, whereas track 2, they have included, along with as needed SABA, as needed ICS with SABA, inhaled corticosteroid with short acting beta 2 agonist. So that's a change which has been done, that in track 2, SABA with ICS has been added as a reliever therapy, along with you got two alternatives now: either use as needed SABA or use as needed ICS with SABA. Now, so that was the only change that has been made in this management of patients who were adults, adolescents, and in children above 5 years of age. Now, ICS SABA has been included in track 2 as a reliever therapy on as needed basis. In track 2, this combination of LABA as anti-inflammatory reliever has been added, and this has been done on basis of only one report which has come up. So before we go ahead, let us discuss this addition which has been done, that what do our experts think about it. Should we start with Professor Guleria?
Thank you. I think this is the addition as far as track 2 is concerned. What I can make out is that GINA is moving away from SABA as a monotherapy in a very aggressive manner. So even if you have to have patients who are step 1, where one was looking at should you give SABA alone or ICS alone with SABA as a rescue therapy, I think they're looking at a combination of ICS LABA in track 2. So the strategy that GINA is having is that now inhaled corticosteroids throughout the spectrum of asthma, even if it is intermittent mild asthma, is the treatment that should be given along with LABA as for symptom relief. So I think this is something which is actually sort of promoting more of track 1, if I put it that way, as compared to what track 2 is doing.
Yeah, there are no changes in track 1, and it's the preferred treatment approach for adults and adolescents. And
if I may add one more thing, I don't know, maybe the experts can comment. Somehow GINA has still stuck with formoterol, has not looked at the newer molecules which have come, which also are short acting and are now coming into the market in a very aggressive manner. So it has still stuck with the traditional ICS formoterol combination and has not looked at the other ultra lavas, if I may say so, which are now in the market. So it has that one was thinking that maybe 2023 we'll see those being mentioned or actually coming as alternatives, but somehow neither in track one or track two have they really come in a big way. I don't know.
Yeah,
I would want
yeah,
others to comment on this also, but this is what I felt.
you're right, because they have only taken formoterol in this combination and talking only about formoterol. And yes, you are right that the attempt they are making is that I mean, a beta 2 agonist should not be used alone. What they want is that it should always be with the controller therapy combination with inhaled corticosteroids. Professor Jindal, you like to say anything about it?
Well,
Yeah.
I think I agree with the points made by Professor Guleria and yourself. The most important issue is that even in mild asthma or the step 1 and step 2, what is important is anti-inflammatory therapy. That is very important. So the bronchodilator part, whether it is SABA or LABA, is perhaps relatively lesser important. The most important is to stress upon the need for anti-inflammatory, the inhaled corticosteroid use, you see. And Dr. Guleria has already said that in due course of time, SABA is going to disappear, since we now have the long-acting kind of beta agonist whose onset of action is also short. So they can be used for symptom relief as well as for maintenance. So perhaps these so-called SABAs, which were popular earlier, perhaps going to disappear. The issue of new bronchodilators, you see, adding to this combination will come up at some point of time, because perhaps enough data is not available about the newer beta agonist molecules, you see, to really say that the onset of action is quick. So they perhaps can also be used for symptom relief as relievers.
Dr. Vijay Kumar like to say something?
Yeah. Looking from the point of view of India, especially where nearly 70 to 80% of our population lives in the tier 2 and tier 3 cities and villages, looking at their socio-economic backgrounds, the big difference between track 1 and track 2 for them would be the cost factor. The track 1 ICS plus formoterol will be slightly expensive compared to the track 2 ICS and SABA. And I think the treatment of asthma has gone a full circle, because I remember that ICS and SABA combination is one of the most popular ones in India and was introduced way back 40 years ago. And there are people who are still using. And from the market survey, it looks like that particular combination of ICS and SABA is one of the most popular selling combinations. But I agree with Dr. Jindal that efficacy-wise, ICS formoterol definitely scores over the ICS SABA combination. And much before the GINA 2023 guidelines came into print form, most of us started practicing ICS formoterol as required for the step 1 patients of asthma. And one of the most important factors, of course, would be the patient should realize that when we say as needed, quote unquote, the patient should realize that it is the right time for him or her to take that particular ICS formoterol dosage. because it is quite common that they may underestimate their own symptoms and then they may miss taking that as needed dose. So that is one important negative point about that as needed recommendation.
Dr. Sarnaik, like to say anything?
Yeah, in fact, if we just review the old guidelines available from different societies, there was always the difference of opinion, like various recommendations regarding the mild intermittent asthma. There were few guidelines where they used to recommend first drug of choice as the inhaled corticosteroids, although the intermittent supplementary short-acting SAMA was also recommended. So I think this current recommendation is jointly now coming up as a solution to there is no variation now. It will definitely be more targeted as an anti-inflammatory therapy. In addition to SOS, as and when required, the formoterol is also going to take up the old short-acting SAMA. So I think this is how we look at this solution, what the recommendation has been.
And the final word from Dr. Deepak Talwar.
Thank you, sir. Thank you for allowing to pitch me in. I was also, like Randeep said, that, quite surprised that no word on Ultralava ICS combinations. They might have not said, perhaps because still the answer is that what will be the rescue inhaler, because these are once a day therapies and cannot be used as a rescue also. And of course, if it has been taken once, so you cannot repeat it, and there's no safety data on it. So I think they would be treading very cautiously on that. But then on the basis of the enough number of trials which are there already and approvals which have been already come for these two molecules, that is indacaterol mometasone and vilanterol fluticasone, it was little surprising that nothing coming in 23, while last year they went a step ahead to talk about TSLP inhibitor as a biological in step 5 asthma, which was still at that point of time still being considered when many countries waiting for the approvals. So I do not know that why this kind of a treatment was given to biologics at that point of time and not given to Ultralava ICS combinations, which are perhaps definitely going to find some place in that by improving the adherence, which point has, I do not know what was the reasons behind that.
And they have not mentioned, yes, really they have not mentioned anything about bringing, okay, because in the future discussions that they're going to have, also they have not mentioned anything about the newer FABAs, which are available in our country, luckily. So with this, I go ahead.
Can I make a point here?
Yeah, please.
No, what I think the point regarding the newer labas or ultra labas being used as SOS drugs as well, you see, as relievers, is that because of their ultra long action itself, you see, so that you may be creating more of toxicity sometimes, possibly, if you are using them on reliever basis. So that is one, I think, point which kind of prohibits a general recommendation for their use for immediate relief.
Right. Thank you. In the meantime, can I request the audience, if they have got any questions they want to put forward to our experts, they may please put them in the chat box, and we'll try to cover as many as possible. Let us see how much time is left with us after that. So there has been no change in track 1, that is as needed ICS formoterol, and this is the preferred treatment approach for adults and adolescents. And these, as I said, this inclusion was basically, it was based on only one trial which was there on SABA with the ICS, that this inclusion has been done. Now, what are the risks of treating asthma with SABA alone? Is the severe exacerbations that can occur once the patient doesn't adhere to his treatment. Now, this is the old 22 guideline picture, and it shows
for children 6 to 11.
Yeah, this was for children from 6 to 11 years. And what they have done is, in the step 5, if you see here, it has got the biological therapy in form of anti-IgE and anti-IL-4. Whereas in this new guideline, what they have done is they just added anti-IL-5 also to the step 5 in children below 6 to 11 years. And what they have said is that this mepolizumab, an interleukin 5 antibody, has been added to the preferred maintenance treatment option at step 5 for children with severe asthma, because what they found in a double-blind RCT that shows that the severe exacerbations with add-on mepolizumab compared placebo, there were a lot of the severe exacerbations were reduced, and that's why they because of this single RCT, they have included this biological drug also to step 5. Now, the comments of our experts, Dr. Talwar, what is your opinion about it?
So this is a very welcome move, because till now we only had a omalizumab which was approved for 6 years and above, and the safety data was awaited for the anti-IL-5, that is mepolizumab, and now at least these two are available. The major impact would be that we were always under the impression that the children will only have IgE-mediated asthmas and they will be benefited by that. But now increasingly it is being seen that eosinophilic asthma also is common in this group of children, and particularly overlap group where there are signals from IgE as well as eosinophil. And perhaps this anti-eosinophilic drugs will be more useful. That's what we thought. But since the data of this double-blind RCT had come only in the last year before, so I think that's why it has been shown that it can lead to reduction in severe exacerbations. And now you have choices of 2 antibodies which are available, monoclonal antibodies, to be used in asthma. So I think this is very appropriately placed at this point of time. But and let's see how much we are able to use in India, this particular indication of using MEPO in children.
Professor Jindal, your comments?
I generally agree. You see what Deepak has said. The only problem is the cost. You see, the cost of most biological, and especially the newer biologicals, especially in this country, is very important issue, and that limits their use to a very small segment of patients. So although I agree it's a welcome move, you see, in that sense we have options now to use the 2 kind of biological monoclonal antibodies, you see, for children, because some of them really need it, you see. But unfortunately, the use is going to be limited. But that does not mean that it should not be recommended for those who need it.
Dr. Sarnayak, any comments?
So I again come to the same point. The feasibility and the acceptability by the population in developing countries is one of the major hindrances. But however, if we have this armamentarium available for this particular subset of patients, we normally tend to see the high IgE as well as eosinophilic count in the pediatric asthma patients. So this will be again a welcome move, but let us see how it in future it is used by the developing countries.
Dr. Vijay Kumar?
As far as the humanized monoclonal antibodies are concerned, we had the efficacy and safety literature available for omalizumab, but not for mepolizumab and pendalizumab. But of late, we are getting the efficacy and the safety profiles through the trials done in Europe as well as in USA. But I suspect that people who require monoclonal antibodies in adults is a very small percentage. And children who require monoclonal antibodies is going to be even much smaller. But it's nice to know that they are available just in case the ICS, LABA, and LAMA fails.
And the final word from Professor Guleria.
Thank you. So I think most of the points have already been covered. It's basically that now with safety data of mepolizumab being there and efficacy in above the age of 6 years, GINA has included that now in their guidelines. But as has already been said, in a country like India, the whole issue becomes the cost, because the treatment is indefinite. We don't have a end point as far as treatment is concerned, and therefore we need to keep this in mind that when you're giving this molecule, you must discuss this with the patient that, it's not a short-term treatment, it's a long-term ongoing treatment, but it does definitely help in improving the quality of life. So it's a good addition to the armamentarium. How useful it will be, as has been mentioned by the other experts, I think only time will tell how much is the utility in this age group.
So the number of cases where these drugs are required may be small, but these severe asthma cases, they are the persons who are perhaps responsible for most morbidity and mortality as well. So addressing these patients would be perhaps a good move, as all of you agree. Then in children 5 years and younger, it's a very simple thing that they have done, that at step 1, they have added that because of insufficient evidence, there is insufficient evidence for daily controller. If you look at the previous recommendation, this was missing over there. But the only change that they have done over here is they've said there is insufficient evidence for daily controller therapy. So any comments, or we just pass it on?
Yes, sir. Inhaled corticosteroids for type 1, step 1 for children is fraught with dangers. Because when we look at the risk and benefit ratios, definitely the risks are more than the benefit. Because many children can have intermittent asthma, and probably they can be treated on demand or as required medication in step 1.
Even post-viral infections and other conditions in children perhaps may require short-term management of this kind. Anyone else would like to say anything over here?
Well, I think it is
a please, Professor Nirias, please.
Other children, it may be perhaps it is better to avoid inhaled corticosteroid, but for children above 6 years, I think they have been fairly commonly used, though may not be on a regular basis, but as needed or shorter periods. That recommendation is there, especially above 5 or 6 years of age. You see, smaller children, of course, perhaps don't really require it anyway. It is difficult to define asthma in those children, perhaps younger children.
We go ahead. Then now they have shown little concern about, the GINA has shown little concern about environment as well. And a new figure they've added on the issue of and the impact of inhaler therapy and impact of critical cases requiring more of critical care support or emergency department support. They themselves have got a lot of influence on the environment. So what they have said is that a proper drug should be chosen for the patients, and a proper inhaler therapy which the patient can use properly, and must be checked frequently that the inhaler therapy what he's taking is taking properly, so that the acute exacerbations, the severe exacerbations that keep on occurring in patients, they do not happen, which will require more of emergency department visits. So the concept of right drug at the through the right inhaler, which one is the best and safest, not only for the patient but the planet. And what they have said is this is the new diagram which has come up, and they say that which of the inhaler has the lowest environmental impact, and they said consider manufacturing, during manufacture, propellant used in the pressurized meter dose inhalers, and potential for recycling. Even at that stage, we have to see what is going to have more impact on the environment. And then they have said yes that the non-adherence leads to exacerbations, and these exacerbations lead to excessive use of more use of emergency departments, which has got its own impact on the environment and the planet, and that should be minimized as much as possible. Comments from the experts, please. Professor Jindal?
I think as individuals, individual patient doctors, I meant to say, one has very little choice about these issues, you see. But otherwise, the points are quite important, and I think these are more for manufacturers, and that they should try to build these things in their manufacturing process and use those. So I think these are important issues in general, but perhaps of less concern to an individual doctor, you see.
I think as far as the individual doctor is concerned, their concern is that we as clinicians, we have to see that the proper drug is chosen through a proper device in consultation with the patient, so that the patient can use it properly. And we should keep on checking at regular visits that the patient continues to take it properly, and that there is no deviation from the right technique. And their main concern is that there should not be severe exacerbations occurring because of improper use of these inhalers, which will lead to more urgent healthcare needs, which has got greater environmental burden. So that is how we come into the play over there. Of course, the manufacturers and recycling of things is not our concern, but we have to. This is what really concerns us.
I agree with that.
Anyone else would like to say here anything? No?
Can I say something, sir?
Surely, yes.
As you said, sir, I think increasingly the emphasis in GINA is going towards patient satisfaction with the device and ability to use, rather than taking the decision by the physician who decides that what device has to go and what kind of the schedule which we are giving the patient. And every year we are finding in the last 3 years the GINA is going more and more towards the patients. And in this cycle this year, they have actually emphasized much more this thing that the device not only has to be taken in confidence with the patient's choice, but also to reassess whether the patient is happy with the device or not, and whether he is able to use it or not. I think these are excellent points, because this is something which the patient is going to be living with for many years. So unless and until they are happy with it, I think physician should not be making a choice on the behalf of the patient. So we are not the custodian there. Actually, the custodian for the device should be the patient.
Yeah, I think that point is certainly important, but sometimes it is contradictory to the choice of drug which you like to use, you see, because the devices are many times specific to the drug, you see, because of the manufacturing companies' issues, patents, and so on. But I agree in general that patient, if he cannot use the inhaler properly or is not satisfied with the device, then there is no idea of prescribing that drug. But many times it may not be feasible, you see, to give every drug with every device. You see, that is the difficult issue.
Professor Guleria wants to say something?
Yeah, so I think what they're trying to say, of course, one is trying to really put pressure on the manufacturers, not only in terms of the molecule, but the production of the devices and the molecule to be environmentally friendly in terms of the manufacturing plant. But also, I think what they're trying to really say is because what is happening is over the last few years, a lot of companies are coming with their specific devices, claiming that they are somehow better than the others. Gina is trying to say that rather than looking at companies claiming the devices are better, it's better to look at what satisfies the patient and what is the patient comfortable with, rather than being driven by what these is being pushed by various industry that this device is better as compared to. We have a large number of fancy devices. As a matter of fact, if you start looking at the inhalers which are available in the market, they seem to be increasing every year with becoming more and more sort of jazzy, if I use that word. So I think they're trying to really say that it's more patient centric rather than looking at what seems good from the physician point of view. But I do agree with what Dr. Jindal said that it has to be that the molecules have to be available with that device. And not only one, the basket has to be complete.
Yeah, they've said that where there is no choice, then of course you can't do anything about it. But wherever choice is there, it should always be a joint decision of patient and the clinician. And the clinician must ensure that the patient keeps on taking using the inhalation device in the correct manner, not only in present but in future as well.
Sir,
Yeah, please, Doctor.
can I say something, sir?
Surely, yes.
In our country, as I said earlier, since 70 to 80% are not from the cities, and most of us are practicing in the cities, looking at our urban patients. In the tier 2, tier 3, and in the towns and the villages, it is the dry powder inhalers which are prescribed more commonly than the metered dose inhalers. And we all know that chlorofluorocarbons, the CFCs, have been banned, and hydrofluoroalkanes have taken its place in the metered dose inhalers. And dry powder inhalers don't have any propellant. It is just the medicine and the desiccant. So that way, I think dry powder inhalers are planet friendly compared to the metered dose inhalers. And I agree with Dr. Guleria that there are any number of new devices which are available. But the one which is very popular is the one which is easy to use. So ease of use is important. I may say that quite some time back, I did a study with the 5 available dry powder inhalers in the market. And then with the help of the biomedical engineering students, we developed a mathematical equation for each one of these devices and derived what is known as a ease of use index. And of course, needless to say, at that point of time, the seritide, which was coming from the GSK, had the highest marks as far as the ease of use index is concerned. And it is difficult to allow a patient to make a choice because he is not really aware what kind of choice he has in front of him. And there are many patients who are uncomfortable with the so-called easy to use device. And they came back and said, sir, I don't know how to use it. So I think sometimes we may have to do trial and error between the MDIs and the DPIs, and whichever the patient is comfortable, probably we have to allow him to use and then come back for a review.
But we must ensure also that it should not only be prescribing an inhalation device. It is our duty to see that the patient is trained properly how to use it. That is, I think, very important.
Yes.
So I move ahead. Management of asthma in low and middle income countries, besides giving advice for management of asthma, GINA is actively contributing to international efforts to improve access to affordable essential asthma medications for all. So, besides thinking about what kind of treatment should be given, they're also trying to mobilize resources that these drugs become available for patients all over the world as well. So I don't think it calls for any discussion. If anybody wants to say anything, fine. Otherwise, we move ahead.
Sir, there are some questions from the audience.
Can we take them later, or
Yes, sir, you can take them later altogether.
we'll take them later. Yes. So the questions are being compiled, and any duplication, other things are being sorted out also. Then there's some updated guidance on managing severe asthma. GINA recommends the use of biological therapy only for patients with severe asthma, only after treatment has been optimized. So this is what they have said. For any biological therapy, ensure that manufacturers and or regulators' instructions for storage, administration, and the duration of monitoring post administration are followed. New evidence and results from meta-analysis of biological therapy have been provided. So this is what has come up again as a new thing, and they have said that severe asthma, where you have taken all the steps to see that these patients are not responding because of other reasons, like use of the inhalation device, like risk factors which have not been taken care of, like comorbidities which have not been taken care of. So after having done all that, then only a case should be labeled as difficult asthma or severe asthma, and then only this this biological therapy should be advised to them. And one of the studies from Netherlands has shown that out of 100 patients, 24 patients they require high intensity treatment, out of which 17%, out of the total, 17% have difficult to treat asthma. And it's only about 3.7% who have got severe asthma. And they say that these 3.7% patients, they are the people in whom the morbidity and mortality is high, and we should take good care of them. So experts will like to give their comments on this, please.
So if I may begin, sir, then
Please.
say that this is actually, I think, emphasizing again and again that giving biologics is to the last end of that severity of asthma, where practically you have tried and done everything and it still does not work. I think this is to prevent the misuse of biologicals. And that's a very good point they have highlighted again and again, and this time also very clearly said. So I think this message is for everybody that if somebody can afford, it does not mean that he should take it. Actually, I think these kind of sometimes requests do come from people who can afford that. We have heard these medicines, we can take it. But if they are not severe asthma, they do not go through that rigorous protocol, and then it's not worth it. And I think that makes a point that using a biologic in severe asthma does require a lot of hard work. And in those situations, you really need to follow the protocols to see all those treatable, difficult to treat asthma things. And I think that point is very well highlighted, that you would require ultimately the asthma clinics where such kind of time can be devoted, where you have that kind of support available, that no point is left untouched before you jump onto the bandwagon of biologicals.
Professor Guleria?
I think just to continue with what Dr. Talwar said, the diagnosis of severe asthma, what GINA has tried to highlight repeatedly, cannot be made on day one. it is something that you need to do. It's a diagnosis which takes 3 to 6 months to make, because you have to really follow up your patients, correct all the reversible factors, look at comorbidities, look at adherence and inhaler technique. And then if you find that despite all of this, the patient is not getting control, then you are making a diagnosis of your asthma. So the highlight point here is that, as has been said by the Netherlands study, the number of patients actually is very few. I still remember a study where they looked at patients who were referred to a clinic for biologicals. And when they looked at just their adherence using electronic monitoring devices, the adherence was only 50%. 50% of people who were referred for biologicals and bronchial thermoplasty were actually poorly adherent. And therefore, it's very important that we first correct all of these factors before jumping onto the biologicals. Currently, I think a lot of people have a low threshold for using biologicals, and therefore, GINA is trying to highlight that this is an expensive long-term treatment, and therefore we should be really doubly sure and make sure that we follow up the patient and check all those boxes before we really start prescribing a biological.
Anyone else will like to say? Professor Jindal, like to add anything?
No, I think I entirely agree with the points made by both the panelists. You see that many times severe asthma may not be actually severe, so all other factors must be taken into consideration before labeling it as severe asthma and then treating with biologicals. And most of these patients do respond to therapy when used appropriately, excluding comorbidities and other diagnoses, etc. And inhaler technique, of course, is the most important issue.
Anyone else? Dr. Vijay Kumar, Dr. Sarnaik, want to make any point?
Yes, sir. In this, some 260 pages of GINA guidelines for 2023, almost in every page, they have been highlighting that attention must be paid to patient education, inhaler technique, adherence, counseling, written asthma plan, etc. So when we do all these things, I think whatever the paper from Netherlands, which was published 8 years ago, says that is what is reflecting in our practice also. There is less than 5% of the patients fall into this category of severe asthma after having done all that that needed to be done. So the biologics probably are indicated only in this small percentage of patients. After having managed the patients, monitored the patients properly, I think that means 95% of the patients can be managed with available drugs.
Yes.
And probably do not need biologics.
Dr. Sarnaik, anything you want to say?
So I think most of the points have been well covered.
Yeah.
But again, whenever we are discussing biologics, it is not only the availability, but at the same time affordability that matters in our region. So This is a very significant and important point, that it should be reserved only for those select patients which are evaluated properly. And if required, in fact, it should be referred to the chest clinics for proper evaluation. That is one thing that is to be, maybe we need to educate more physicians and the family doctors on this issue.
So then we've got some other points that have been raised. Is one of them is pulse oximetry in dark skin color people. FDA has issued a safety communication that there is a potential of overestimation of saturation in people with dark skin color. Now, errors can always happen in these patients, and especially when the saturation is below, say, around 80% or so, that these problems arise more. So what are the comments of our experts on this? Professor Jindal, you want to make any point?
That issue has been kind of taught in books off and on. See, there is no real but now they have included in because it is now being very commonly employed, you see, the oximeters.
Yeah.
Earlier it was not that common. So I think it is a good caution to know that. That's all I would say. You see.
I move ahead then. Then there are other recommendations. I'll just keep on telling you small recommendations that come up. A brief section on imaging has come up in the diagnosis of asthma, which is what they have added on to it. Pertussis has been added in the differential diagnosis of asthma and in its exacerbations. Anybody would like to make any point, please let us know anywhere, or I'll just keep on naming them. What changes? Advice about how to manage asthma in during the COVID-19 pandemic. What is the role of FeNO in children in reducing the exacerbations by monitoring these cases with FeNO along with the symptomatic relief that they get? Update on role of digital interventions in adherence to treatment. A Cochrane review has shown that improved adherence to asthma medication, reduced exacerbations, and improved asthma control has been seen. Then fragility fractures, that is what they have also mentioned, that the cumulative adverse effects of exposures, what they have said is the exposure of oral corticosteroids cause not only osteoporosis but also fragility fractures. Non-pharmacological treatment in form of physical activity in moderate and severe asthma patients provides benefits. New evidence has been added up from a systemic review. Then outdoor air pollution, they have said that higher pollution has had an impact on asthma as seen by increased medication utilization. And this usually is seen after a lag of 2-3 days. Then vaccinations, they may recommend additional evidence included on safety of influenza vaccine. However, there is insufficient information on routine pneumococcal vaccination in adults. And then updated advice on definition of mild asthma, clarification of terminology for asthma medications like terms like controller. It has been replaced by maintenance treatment or ICS containing treatment. Terms like AIR and MART have been discussed. New practical guide to management of asthma exacerbations, details on medication and dosages, action plan on maintenance, advice on potential drug interactions with drugs for conditions like COVID-19, ABPA, and asthma control questionnaire recommends that ACQ5 is superior over ACQ6 or ACQ7. And then finally, the topics which are still under discussion at GINA, they are diagnosis of asthma, they are assessment of symptom control, allergen immunotherapy, severe asthma in children 6 to 11 years. So these are the topics which are under discussion, and maybe in some of the future reports that we get from GINA, some of these would be covered as well. So would anybody like to make any comments on these things?
Sir, we need to
Sir, about the
another seminar because there is almost a lot of other things, and they need to discuss. I think we should make it part 2 and come back again with the rest.
We can go to the questions you see in the chat box.
Because I think all of these topics are something that we need to discuss separately, because in our setup, especially in the Indian context, all of them have a lot of relevance in terms of both assessment, diagnosis, how does allergic immunotherapy sort of pan out in our own country. So maybe Dr. Talwar can plan another seminar looking at topics.
So long as my panelists are ready, tell me the date. We will definitely do it, because I think when Dr. Katiyar sent it, air pollution was something which they mentioned actually.
Yeah.
to leave the home. Actually, I think that is very relevant to India, and I wanted Randeep to talk about it, but I think we will have a second seminar on this part 2 of GINA 23. We'll take questions. I think Dr.
Yeah, let us take some questions now.
The point made by GINA about the dark skin and pulse oximetry
Yeah.
probably is related to African countries.
Yes.
Because in my practice, in the last, say, 40 or 43 years, I never had any problem with my patients' skin and pulse oximetry because probably we are not dark skin, we are brown skin.
Yes.
Maybe dark skin is referring to the African countries and people there. Yeah.
There's a question from Dr. Ankur Gupta. How to evaluate response of treatment in patients who are unable to perform PFT and peak expiratory flow rate, and how to titrate medication in this patient subset?
I think ask this question, Dr. Jinder.
I think it is not necessary to perform PFT in every patient to see the control, and the questionnaire is best suited to assess their control. You see, and there are many times 5-item questionnaire, 6-item, and I suppose that GINA has recommended the 5-item
Yes.
questionnaire as the most applicable. So it is not necessary that unable to perform means either it is very severe asthma, so the history is more important, and the ACT score, you see, the ACT score perhaps will guide to decide the treatment, and other, of course, clinical examination and other parameters, you see.
So if I may just add, even if a patient is able to perform spirometry, then also assessment of response is more based on your questionnaire, ACQS, or symptom control, rather than doing repeated PFTs to see whether the patient is responding or not.
Sure.
Right, yes.
It's important for us to understand that spirometry has a limited role in seeing response to treatment. It's good for diagnosis, but I don't think it's a tool for trying to see whether you can step down or step up as far as asthma control is concerned, looking at spirometry.
It's a poor correlation with the asthma control, actually. The FEV1 is a poor correlation with the asthma control. So that may not be necessary at all, actually, I think.
Then
And
Dr.
I have
please.
I have looked at all the literature available for fraction of expired nitric oxide and oscillometry, which are being now pushed and promoted as newer lung function tests. But I'm not really convinced with their use in our routine practice. Probably, like everybody said, asthma control questionnaire is the best. And especially when it comes to children, parents are very eager to come out with the proper answer for all the questions that we put them across.
Dr. Thita Mohanty has put up a question: triple therapy versus dual therapy in difficult to treat bronchial asthma, then he says introducing LAMA after bronchodilation achieved by ICS LABA for better debulkation by. So will somebody like to comment on this triple therapy versus dual therapy, when to add LAMA in these patients and when to withdraw LAMA or keep continuing it? What should be done? How long should triple therapy be continued?
GINA has already introduced it into step 4 now. So basically, at a moderate dose of inhaled corticosteroid, the choice is to add LAMA before going to high dose of inhaled corticosteroid, which is in step 5. So this was the same in last year GINA, and there's no change in this year.
Yes.
The triple therapy has entered into GINA step 4 and step 5. So I think that is very clear. There's no change in that.
And I think I'd just like to add that triple therapy is useful, and it came up after, I think, 2016 with the study in NEGM which showed tiotropium to be useful. But data in terms of whether it improves the dyspnea is still, we need more data on that, whether adding a LAMA to a LABA with ICS does lead to better control, but triple therapy is definitely something that one can consider in step 4, especially if a patient is not responding to medium or high dose ICS LABA.
Patients in step 4 and step 5 who are requiring, in addition to ICS and LABA, a LAMA, the number is quite high among the adult patients, but not so in children. I'm yet to put a triple therapy in any of my children patients, whereas among the adult patients, it happens quite frequently.
Then stepping up and stepping down with the in ICS LABA or ICS Ultra LABA.
So there was one more part to it for the earlier question. The second part says that when the asthma is well controlled with triple, so should we withdraw LAMA?
So there's no guideline actually what we are discussing today. These are the out of preview questions basically, but I think Dr. Katiyar will allow this and allot to one person because we don't have any further time. We have just about 15 minutes and more than 15 questions. So I think I'll request Dr. Katiyar to allot the question to someone answering that, and that I think we can take forward. So this part, which is like first to withdraw the LAMA or to decrease the dose of ICS. There is no guideline, but I think Dr. Jindal can elaborate on that.
I think if it's a person is using the high dose inhaled corticosteroid, so it may be better to reduce the high dose first, you see, rather than withdrawing LAMA. So, but there is no definite kind of recommendation in the GINA guidelines as far as I know, but otherwise I would certainly like to depend more on inhaled corticosteroid dose because that is the most important to decide the step up and step down treatment as well.
We'll take one or two questions more. There is one which says, why wait till stage 5 for advising biologics when airway remodeling has already occurred? Why not give at earlier stage? Dr. Talwar, for you.
So obviously we have discussed enough about the cost. If it comes to the cost of an inhaler, then obviously the things will change because there is a data emerging with the biologics which is showing that it will prevent remodeling which is happening. So you won't be having asthma with fixed airway obstruction because it is taking care of that inflammation at an earlier stage and before actually they can become fixed airways. So there is a data which is coming up, and if that is good enough and finally the cost of the therapy comes down, and we know that biosimilars are there on their way in asthma. So I think the things will change in future, but not to the extent where we can think about using it much, much earlier. And I think people are talking about GINA step 4, and I still feel that it is not step 5 only, but it is end of the step 5 where everything has been tried.
There's one question that Dr. Deependra, GINA emphasizes for written asthma action plan. What is the opinion of experts regarding feasibility in India? Dr. Vijay Kumar? Yeah, please, Dr. Professor Guleria, yeah.
Yes, sir. I practice it. I do practice it. Written asthma action plan. It is doable, practical. And as you write down, you keep explaining to the patient. They understand. In fact, they like somebody writing down the action plan because sometimes ahead of us, they ask, sir, what if the symptoms increase? What do I do? What if the symptoms get much worse? Which hospital do I go? So these questions are already floating on the mind of the patient. So it is better that we put down on paper how to increase the dose of ICS LAMA and when to introduce oral corticosteroids. If we have to introduce oral corticosteroids, you can always write down a small box which says magic pills. And as per the patient's body weight, you put the dose once a day. for 5 days or 6 days. Patients like it, and I have not seen a patient who has misused using those oral corticosteroids, although it has been prescribed as an SOS thing. So it definitely is workable, doable, practical, and it should be done.
Dr. Subodh has asked when to consider CT thorax in case of asthma.
Dr. Sarnaik, you can take this question.
In fact, again, we will be focusing at subset of bronchial asthma patients who are severe asthmatic, and then of course we suspect comorbidities because they are not responding to adequate treatment. Of course, the classic example can be early bronchiectasis with ABPA can be missed out. So they, in fact, might be poorly responding to the usual recommended aerosol therapy and keep frequently requiring oral corticosteroids. So those subset of patients. In addition to that, now we see lots of overlap of COPD and asthma. So wherever there is a suspicion of a poor reversibility, that would be another subset of patient where we can find air trapping or the localized air trapping or emphysematous bullae, which might be missed out on routine X-ray chest. So likewise, there are expected comorbidities where the CT scan would be indicated. Otherwise, isolated exacerbation of bronchial asthma with severe bronchospasm, there can be bilateral symmetrical air trapping, but that probably may not be the indication for CT scan. So unless we suspect a lung parenchymal illness in addition to the bronchial asthma, that will be one clinical indication of CT scan.
Anyone would like to add or say anything about it? So I call it the, yeah, please, somebody.
Sir,
yeah.
A good plain chest X-ray, if it is normal, then there is no need for a CT scan. I would think of a CT scan only in 2 or 3 situations. Number one, in children, where you are suspecting a congenital issue, a congenital bronchiectasis or a large cyst or something like that. And in adults who are smokers, as Dr. Sarnaik rightly mentioned, who also may have COPD, and if they are smokers, I would like to rule out any malignancy, because low dose CT has been shown to be quite useful in picking up at least 1% of lung cancer among the smokers in adults.
So what you have said is a good chest X-ray. When you say good chest X-ray, it's a rarity, because especially in tier 2, 3, 4 cities, it's very difficult to get a good X-ray chest available commercially. You won't really get, because if you get a good X-ray, it's very informative, and perhaps it prevents going further for CT thorax in many of the cases. I call it the last question for comment. How can we leave the choice of inhaler on patient as patient is more or less unaware about the various device and its pros and cons? It's not a question of patient making a choice, patient being offered the options with telling him the benefits and seeing what kind of patient he is, whether he can use it or not, giving him a trial, give him a trial with placebos and see what he can use, and accordingly he can make a choice. Not that he will come and say that give me a DPI or give me a MDI, not like that. So it's not a question of giving a choice to the patient. It is helping him to make a decision, helping him and helping you to take a joint decision, so that a proper device can be prescribed to the patient, and that device the patient is made to use it there, and he should be trained very well, and during a subsequent visits keep monitoring whether the technique is still proper or not, because it has been seen, there have been reports that with the passage of time the technique deteriorates and you need to keep on rechecking it. So with these few words, I'm grateful to all of you because when Dr. Talwar told me to join this webinar, when I saw the names, I thought it's a very simple thing because with so many experts with me, my job is done. And this is what you have really seen, that the job has been done so well. I mean, it has been, I'm really thankful for all of you for giving your precious time for this webinar and discussing something. Perhaps we are discussing for the first time in the country about the GINA report. So I'm really thankful to all of you for sparing your time, and I'm sure in future we'll meet again. Thank you so much. And I also thank the Glenmark for the educational their mission to bring forward the educating the young people on this pulmonary medicine. Thank you so much.
Thank you.
Over to Glenmark.
Enjoyed your
Dr. Talwar, please. Yeah.
excellent kind of.
Thank you, Dr. Katyar, for this excellent moderation. We knew that you'll be able to carry on with this entire updates and the new features which have come up in GINA 23 so well. And it was really inciting. At the first look, it looked like that there is nothing new in this, but you brought such a thoughtful, provoking points that it has many things which can be. And we have all learned that there are many things which still need to be addressed. And we being the first one to discuss the GINA 23, with the help of my moderator as well as the panelist, I would be coming back again with the part 2 to cover the rest of the GINA update, because there are many other things which are important. And I think sometimes reading between the lines makes all the difference, which only the senior people like Professor Katyar, Professor Jindal, Professor Randeep Guleria, Professor Vijay Kumar, and Dr. Sarnaik with me can be able to help us and everyone else in that way to get into the nitty-gritties of this GINA 23. So we will be again there. One more Respinar is required for that, and our knowledge partner, Glenmark, who continues to help us and continues to see to it that we every Wednesday meet on 8 p.m. And today I'm missing Richa, but next Respinar, Richa will be back. Today she is busy. And we'll be back again very soon. We'll be declaring the date, which date we are going to discuss the rest of the GINA 2023 with our expert panel as well as our super expert moderator, Professor Katyar.
Thank you so much. Thank you. Thank you very much.
Thank you.
Thank you.